Welcome. So thank you everyone for coming for our last Represent Sky of the season. So we'll be taking a break for the summer months and then we'll be back in September. So today we have Dr. Jeanette Hayward and Dr. Kyle Miller to talk to us about complex care and the Manitoba experience. So for people who are on the webinar, if you have any questions for Jeanette and Kyle, just type them into the chat box and I'll read them out to them. And I'll also post a recording of the webinar on our website afterwards if you want to watch it again or share it with somebody else. And I think Barb has an announcement that I don't want her to make.
Don't worry, I won't cut into your time much. Some of you already know this, but I thought this is a good opportunity when we're all here. Our valuable and beloved Jessie is moving to Ireland. So this is her last Breakfast at Sky. I'm happy for her, but I'm sad for all of us. Thank you for moving us forward, pushing us along, doing whatever needed to be done. We appreciate it.
So hello everyone. I'm just setting up here. Hello everyone, my name is Kyle Miller, so I'm one of the complex care physicians, and I think everyone probably knows Dr. Hayward. She's has much more presence here than I do, also a complex care physician. And we'll be presenting children with medical complexity, complex care, and the Manitoba experience. So we have no conflicts of interest to declare. The objectives or the contents really should have been titled. Firstly, I'll present the current definition of children with medical complexity. Then I'll be the one presenting medical, social, and systems, medical, social, and social resource challenges these children and their families face. I'll then explain the complex care as a specialty and the benefits the field provides. And then lastly, the last half of the presentation will be Dr. Hayward. She'll present recommendations for care for children with medical complexity and give a more in-depth focus on what our Manitoba program looks like. So the first objective, the definition. So this is busy, just bear with me. So really the definition of these kids started in the early to mid 90s. There was a lot of focus on chronic conditions. So children with chronic conditions, they were becoming more and more prevalent. And there was a lot of interest on these children, their system navigation, their prevalence, standards of care. But what quickly became apparent really in the 2000s, early 2000s, was there was a subgroup or an outlier group of this group of children, which we now know as children with medical complexity. And they had the highest fragility, they had the highest complexity, lots of resource use, and it became clear that these kids really need an independent sort of stream of study. And that's where we started focusing on children with medical complexity and how are those kids defined. Early on in the early 2000s, it was just really, we said these kids are complex if they have a list of diagnoses, and we determined somewhere, experts somewhere, determined that these diagnoses were associated with complexity and fragility. And that's really not a very specific definition. So things started evolving, and then really in 2011, with this paper from Yal Cohen and other leaders in the field, that's when we started getting a better framework how to define these kids. So I'll walk you through it now. So firstly, let's start with the chronic conditions box. Oh, and the kids need sort of one of each of these things. So chronic conditions, so these can be diagnosed or suspected, and they really should be associated with high severity or high fragility. So they have the condition. Next is high healthcare use. So this is high healthcare resource utilization. So perhaps they're in and out of hospital quite a bit, lots of ER presentations, lots of subspecialists. Those would be examples of high resource use. So you have the condition, you're in and out of hospital a lot. Then the functional limitations is another big one. And again, this has to be severe. And then often that functional limitation is overcome with technology. So these are we see a lot of these kids in this center. So for example, let's say you have a functional limitation with feeding, either dysphagia or aspiration, you get a G2. That would be an example. Or breathing because of airway collapse, respiratory failure, then you get a trach and vent. That would be the type of thing we're talking about. And mobility also fits in there. And lastly, needs. So we have these three, but needs is really that big one, and it's the most subjective. So the two examples we have here are substantial family identified service needs, and that can be medical services or community services, but also the significant impact on the family. And this is really the needs, usually family needs like this. And the example in the literature over and over again is financial burden, but it can be stress, coping, PTSD, mental health, all sorts of things the family needs can come up. So that was in 2011. and that definitional framework sort of moved us forward, but wasn't expanded on until 2018 when the Canadian Association of Pediatric Health Centres, now Children's Healthcare Canada, came out with this policy document, and Dr. Hayward was one of the advisors on this committee. And they really tried to expand on that original definition. As you can see in the first column, family needs, chronic conditions, healthcare use, those are the same variables, very familiar. But where this definition was really pushed forward, was the second column. So we really took those subjective headings and gave a conceptual framework to them to try and give us a little more clarity on what do we mean by family needs. And then the next column, operational criteria, a lot of work was put into examples of operational criteria, but this is where it's still subjective. So we haven't perfected that jump from the concept to a checkbox that says, for example, healthcare use, they need more than 2 medical subspecialists. Yes, no. We haven't got there yet, but there's a lot of work continuing to move that definition to a really solid operational criteria. And just to let you know, again, with this framework, the child needs one from each of these to sort of get the label of child with medical complexity. And this is informing much of our entrance criteria across Canada, to our clinics, that is. So that's on paper, a little cold, a little dry, but what does that look like in real life? So these are published examples of children with medical complexity. So the child may have a congenital or acquired multi-system disease. They may have severe neurologic condition with significant functional impairment. They could be cancer or cancer survivors with ongoing multiple disabilities. And I'm going to pause here because a lot of children that already have medical homes are still children with medical complexity. So a cancer survivor would be in hematology, oncology world, chronic kidney disease. Those kids could be medically complex, but they already have a home in nephrology. So the kids we see here are more the ones without that medical home, but you'll hear more about that from Dr. Hayward. And lastly, a genetic syndrome with associated congenital heart defect, difficulty swallowing, dysphagia, cerebral palsy, urologic condition. I hope we start to get that idea of what these children actually do look like in real life. So that was published examples. Now here's a case that we came up with. Now this is a composite case of multiple kids, and we were contemplating using a real case, but that really highlights why what we do is so unique. So we couldn't use a real case because these kids are so unique that they would be identified and people would be like, oh, that's Jane. And that really shows how individualized the care is for all these kids and how hard it is to have a standard of care for children with medical complexity, because every child is very unique with their diagnosis, their needs, their family needs, their functional limitations. It really takes a lot of problem solving. But this child is a 4-year-old living in a rural setting. Child was born with microdeletion, with significant brain anomalies, has cerebral palsy, significant spasticity, significant dysphagia with a history of aspiration pneumonia, multi-drug resistant epilepsy, unfortunately had a complication secondary to one of their anti-epileptic drugs, so gets kidney stones, and then has chronic lung disease. Currently, they're followed by, so we're getting the flavor of the diagnosis part of that definition here, I think. Quite a few complex diagnoses. Currently followed by multiple subspecialists and therapists, and in the past years had 2 prolonged hospital admissions, one for pneumonia, one for status epilepticus, a seizure that just wouldn't stop. So we're sort of now seeing that healthcare use is becoming more and more, and we see that with our kids a lot. All of a sudden they'll have a year where they present as, oh, they're in and out of hospital, they're very fragile. But during these admissions, we had a GT placed for aspiration risk, and home O2 is initiated for persistent O2 needs. So now we're starting to see that functional limitation with technology assistance. And then family found to be using a commercial stroller for mobility. And remember, this child's 4 years old. So now we're starting to get that flavor, but here's the family needs, and it really comes out. Parents recently separated, and unfortunately we see that a lot when families are looking after children with medical complexity, just because of the stress. The family is overwhelmed with new care demands, so we saw the changes in their care in those admissions. Now they have multiple increased number of new involved specialists, number of increased appointments, on top of the new care demands that all these new decisions have left for the family. And then the family is concerned about the demands of specialized care and fragility in a rural setting. And we do see this a little bit. So when you have a child that is that unique, that has that unique care level of care, parents often feel uncomfortable in the rural setting. So for example, the emergency response, so if something were to go wrong, which with these kids, unfortunately, it happens relatively frequently, they are very far from the nearest emergency response. So they're rural hospital or even getting themselves to Winnipeg to a higher level ER. Lack of familiarity. So a lot of the rural setting isn't familiar with these really unique diseases and unique levels of care. And the families often feel isolated because they're away from social support networks. Their primary care is often in Winnipeg. Okay, definition. So I got through that, but that's an important part because the definition really is not totally solid yet. And a lot of our decisions are made based on, is this child a medically complex child? So it's evolving. So now I'll present the medical, social, and systems resource challenges these children and their families face. So I'll start with the numbers, so the pure epidemiology. So this was a study in 2012 where they looked at the administrative data of Ontario, and they found that children with medical complexity make up 0.67% of the entire pediatric population in Ontario. Now, this was using a definition that looks at just the disease, the list of diseases. So when they added, the second point here, when they added the requirement for technology assistance, which can also pull from admin databases, getting closer to that 4 criteria, then we saw it was 0.08% of the pediatric population. So we're dealing with smaller numbers here. But if we were to extrapolate that to Manitoba, based on our pediatric population in 2017 of 335,000, that would be roughly 2,200 children with medical complexity with the diagnosis. And with the 2 criteria, then we're looking at about 268, 270 when you look at the diagnosis and the technology assistance. So a decent number, but the impact will really come out in the next couple of slides. And just to give context, we see about 50 children in the complex care clinic, and there's some other medical homes where these kids will be found in as well, but that's only 1/5 of the estimated out there. So this is now the numbers. So the bean counting here, the dollars and cents. I'm going to pause here. The dollars and cents are important because we're in public healthcare. Resource allocation is incredibly important. However, each of these dollars represents an appointment, a hospital admission. All of this money shows the stress that is put on these families as they access healthcare because their child is so complex. So this is that same study from Ontario. So remember the 0.67% of the population? They actually use 33% of all pediatric healthcare resources in Ontario. So less than 1% using roughly 1/3 of the entire province's pediatric healthcare utilization. When you look at that 33% and break it down, half of that is due to the index admission, so that admission where we identified them as a complex care child. Readmissions, 27%, home care, 11%, and physician services, 6% of the 33%. I'll point out though, the home care part of it, if you were to add that technology assistance piece, that flies to the forefront as the number one for these kids, and it's roughly 70% of their expenditures is home care. Down below this point, this is from a different study in 2006, and it was analyzing one of the American states' medical care expenses, and they showed if a child had medical complexity, they used roughly $70,000 per child in Medicare expenses, and that was compared to their controls of $3,000, so there's 22 times more. And even these controls were still children that were once hospitalized, so if you compared them to the actual background population, it would be the controls would even be much less than 3,100. So I think we get that there's a lot of healthcare resources that these children require. So this is a study where I wanted to really highlight, that was the population level. Now what does it look like inpatient? So what is it in hospital? What is this kid's presence? This was a study from 2010, and they studied a database that included many children's hospitals all across America, and they compared 1997 to 2006. So firstly, pediatric admissions. Of all pediatric admissions in 97, 9% were children with medical complexity. That increased to 10% in 2006. So a small increase. Inpatient days increased from 22.7% to 26%. Hospital charges and hospital deaths both likewise increased. The big increase though was found with technology placement or technology revisions. So if you had a coded procedure that had to do with a technology placement or revision, 73% of those were children with medical complexity in 1997, and then 2006, almost all of them were, so 92%. So we see a big increase over that 10 years, as well, we're seeing that most children getting technology in this study were children with medical complexity. A lot more technology sort of keeping these kids functional. Okay, so that was the dollars and cents. That was the inpatient presence. And I hinted at the impact on the family, but these next couple of slides will really get into that. So this was a study in 2011, and they did a sub-analysis of a nationwide survey in America. And what they found is if you were a parent of a child with medical complexity, you spend a median of 2 hours per week on care coordination. And that just means trying to navigate the system, not even caring for the child, just trying to get them to appointments and organize their care with a dizzying amount of subspecialists, primary care, therapists, etc. These parents spent anywhere between 11 to 20 hours per week on direct home care, so almost a half-time job to look after these children. 57% reported financial problems, 54% reported that a family member had to stop working because of the child's health, and that really comes through considering a half-time job just to sort of care for these children. 48% reported at least one unmet medical service need, and then 33% reported difficulty in accessing non-medical services, and that would be community recreation programs, school programming, that sort of thing. It's quite difficult. A lot of stress here, and then this slide sort of gives us an idea what that stress may be doing to these parents as well. So this is two studies. The first half was a study in 2009, and this was a Canadian study, and they surveyed parents who were looking after children with disabilities, not necessarily medical complexity, but a lot of overlap in those two populations. And they found that 2.5 times more likely, these parents were 2.5 times more likely to have a chronic condition themselves, 2.5 times more likely to have activity limitation themselves, 1.5 times more likely to have poor general health status themselves, and 2.5 times more likely to have elevated depression scores themselves. So this could be from the care, and I think a lot of this is from the care of looking after these kids and just the stress and what it happens to these parents' mental and physical health. However, this study couldn't differentiate whether there was sort of a hereditary link, like the parents had the disease in a less expression than the children. But still, I think a lot of this numbers is from the stress. The second study, this was a nationwide study from Denmark, and they showed that if a mother were to have a child with a congenital defect, so a subset of children with medical complexity, they had a 27% increased risk or hazard of maternal mortality themselves. So they were more likely to die than the control population if they had a child with congenital anomaly. The median follow-up was 21 years, and the absolute rate difference was an increase of 0.33 deaths per 1,000 person years. And again, they couldn't control for the hereditary piece I was talking about. Okay, that's a lot of information, but I think this really shows why life for our families is so stressful and why systems navigation is just impossible for some people, most people, honestly, without help. So this was published in 2016. It's a care web. So, yes. So here in the center is our family. And then this is all the people that are involved in the care of the child. And I honestly had no idea how dizzying it was until they put it on paper like this. So here in the blue, this is the health section. So this is the stuff we think about. So we have subspecialists, we have pediatricians, we have pharmacists, psychiatry, lots of different healthcare providers, but even things like dentists we sometimes forget about. They're involved in the care of these children too. Here is a subset of that, the developmental assessments, so neuropsych, speech, CDC here in our center. School is huge. This takes up 8 hours of their day. And things you would think about, the school nurse, the EA, the teacher, but then even stuff like the bus driver, I didn't think about. Because these kids are, I'm preaching to the choir here, I'm sure, but a lot of these kids have mobility issues, and the bus driver is a care provider for them. When we move over here, this is this family's world in information advocacy and leadership, so advocacy groups, either disease-specific or disability groups. Recreation and community, a lot of families have trouble with this, but this is stuff like after-school programming, swimming programming, and all the people that are involved in that and the care that they provide. Legal and financial, so a lot of estate planning, a lot of tax rebates, so huge part there. And then lastly, just the family support, so babysitters, alternate caregivers, family, therapists, their daughter in this case, they all have to be trained on these children's care so the parents can actually have a moment. So let's say that one cardiologist makes a decision that changes. Yes, it'll change all the care for everyone else. That has to be filtered through our family and then filtered to every one of these different arms, because now care has changed everywhere. And I think we forget sometimes how one decision can have a ripple effect that changes everything. Okay, last objective. So I'll explain complex care as a specialty and the benefits the field provides. I'm just checking my time. I'm doing okay. Okay, complex care in North America. So in the early days, so mid-2000s, we started seeing more and more complex care programs, and this really started in the States, but Canada quickly picked them up as well. And back then, there was no standards of care that were solidified. Even our definition wasn't yet solidified. So as you can imagine, a lot of these programs had similar goals, but slightly different look. Some were inpatient, some were outpatient, some were medical homes, so this is their primary caregiver. Some were consult-based, so they worked with a primary caregiver. There was lots of different models. But the common goal, so this summary was published in 2016, the common goal of all of these is to optimize the health and minimize the resource needs through care coordination. That was the primary goal of all of them. In Manitoba, just to give a little idea, and Dr. Hayward's going to delve into this much more deeply, we are an outpatient program, but we did evolve into an inpatient presence, but predominantly we're outpatient. We're consultative care coordination model, so we're not the medical home, but we consult with the subspecialists and the primary care providers. We are, though, the subspecialists. We provide subspecialist care, so the medical home for feeding. That was the program originally evolved out of the feeding clinic. And then we are a multidisciplinary team, and we have a nurse clinician as the primary family contact, Gail Bonin, sitting in the front row here. So back to the case. So sort of highlighting what we do. So we determined that this family would benefit from enrollment in the complex care program. So we start with a holistic assessment of the child's current and future medical and community participation needs. From there, we created a comprehensive care summary and plan encompassing medical as well as participation needs, including acute care. And this is really actually the most beneficial for our hospital colleagues, because these kids will come in often with the same problem over and over again to the hospital, and then we have a care plan that's laid out on what to do when these kids present. So navigation of intercurrent illness and acute deterioration. So this is the inpatient presence when they have to be admitted or the ER. We liaise to help everyone that doesn't know them as well figure them out. We balance the family and medical team goals, and that's often a difficult balance to make. And then this whole time they're in our program, which can be months to years before eventual graduation, we work on family empowerment, so educating the families, empowering the families to really take over the role of care coordinator and system navigator. And really the families do get this with time as they become more comfortable. So the benefits of complex care. So I'm going to present 3 slides, and these are all pre and post assessments of whatever outcome I'll present for complex care programs. So they created a program, did a pre-assessment and a post-assessment to see the impact. So this one was a program of care coordination was their model, and they had a nurse clinician and physician as their primary providers. And they showed that pre and post, they saw a decrease in 9 to 10% reduction in inpatient admissions, 52% reduction in total inpatient days, 44% reduction in hospital charges, and 7% reduction in outpatient physician claims. So yes, saves the system money, but that's also all the decreases in admissions, going to appointments, that's all beneficial for the families and their coping. One problem with this and the next study is our kids, as they get older, just naturally stabilize, more reserved, the families get a little more comfortable. So some of this, not all of this, will be biased by that fact, but these are still impressive numbers. This program, again, did a pre and post, and they were a care coordination model. Multidisciplinary team, but they targeted for this study children with neurologic impairment and feeding tubes. So a more specific sort of look at our children's medical complexity. They showed a 32% decrease in average inpatient length of stay, so that's good. They showed a $5.2 million average annual savings to this American network, this HMO network. So $5 million savings. Cost of the program was $663,000, and they reported a return of investment of 680%. And this is really why a lot of these programs started, because the HMOs identified them as cost savings, and then the benefits to the family, the system, all really became apparent when these programs were created. Lastly, and this was another pre and post, it was a care coordination model by a multidisciplinary team. This one, though, did correct for that era effect, that stabilization effect I mentioned. And this one, though, looked at the parents' perspective. So they surveyed the parents pre and post, and they showed that fewer parents needed help with care coordination, which is great. That's family empowerment. 78% required it, down to 30% post-enrollment. Parents were less likely to miss greater than 20 days of work per year. That decreased from 26% to 14%. And again, a nice improvement. I just want to point out, though, that before enrollment, over a quarter of these families were missing at least 20 days of work. And if you have kids, that's mind-blowing. I don't know. A lot of employers would not be that accommodating to miss 20 days. And that really shows why a lot of our families have to quit work. And then hospitalization, greater than 15 days per year, that decreased from 57% to 43%. So we saw nice improvements in the family life as well. So better for cost, better for health outcomes, and better for family life. Now that's the end of me, so Dr. Hayward will take over here.
Okay. So now I'd like to talk a little bit more about recommendations for care for children with medical complexity and our Manitoba program. So we actually started developing our program back in 2014, and as Dr. Miller mentioned, it originated within our existing feeding clinic that I think everyone here is well aware of. That was started by Dr. Rempel quite some time ago. And our program is unique like every program. I think you guys are getting a bit of the picture that complex care is an emerging field and there are differences across the country. But it is really unique. I think that we are situated within our feeding clinic. And so we have this unique ability to capture a lot of the kids that would benefit from our program from the outset, and also once they've graduated from complex care, still be able to follow up with the families and see how things are going as they're often continuing in that feeding clinic program. So our team, again, I think you guys know most of us. Vera Sad is the other physician that I haven't mentioned, and I saw her walk in the back. I don't know if she's still here. There's Vera. You can do a wave if you don't know. And then we have an inpatient nurse clinician, Joanne Brown, and then as Dr. Miller mentioned, our outpatient nurse clinician, Gail Bonin. I think the other really special thing, and I'm calling it partnerships because I think we all are partners here at this center, and I hope I've captured everyone in this building, but I think it's really amazing that we are able to come together, coordinate appointments, collaborate on kids, join in on each other's appointments. This is so valuable for us to help families with their service navigation, to help with, combining visits and decreasing time away from work and other areas of life that they need to be in. And I've really appreciated the collaboration that I've had with the various team members in this center. I think it's such a strength. I think it's only going to continue to strengthen as we grow and learn more about whatever everyone else is doing and understand each other's programs. But again, this is a really important thing that not everyone has access to if you have a program that isn't connected to a center that has all of these different areas and clinics available. So Kyle already mentioned that in 2018 we worked on a guideline. I know Maria's in the audience. She was on that committee too, I believe. I'm not sure if anyone else here was, but I just want to go through some of the recommendations that we came up with. So first is to ensure that the process for clear identification of children and youth with medical complexity is in place to promote equity of services. So really we want to be able to uniformly identify these children across Canada so that we can address all care needs of all children with medical complexity across the nation per Canadian guidelines, while still allowing for individualization of different programs, knowing that there's different capacity, different program implementation, different funding models. But we do want to start unifying the process so that we are all looking at the same thing and having the same objectives across the country. and Kyle already presented this. This is the definition that we have adapted, originally published by Dr. Cohen. So I just want to go through in a little bit more detail what our entrance criteria are, and these are published in that CAFC paper as well. So family needs, Dr. Miller already mentioned this, there needs to be a significant impact on family, and this can be finances, this can be time, healthcare visits, unmet care needs. The child would require significant and continuous monitoring due to their fragility or risk of life-threatening deterioration, or self-reporting from a parent who feels unable to cope with either the overall medical need, financial need, time needs, etc. Second, looking at chronic conditions. So as was already mentioned, having an existing condition that's associated with fragility, there's a risk of a severe rapid decompensation in homeostasis, meaning when the child is well, everything seems stable, they have an inherent risk for something really serious occurring. Third would be healthcare use, so having a really predictable high healthcare service use, either through multiple care providers, multiple or prolonged hospitalizations, and care services are delivered in many, many different settings, so school, home, hospital, community clinics. And then functional limitations, so unable to do activities of daily living because of impairment in one or more body system, eating, breathing, elimination, or mobility, requiring constant surveillance due to the complexity of their condition, their medication usage or therapy, and dependent on assistive technology for at least part of each day. And then we have some program-specific criteria. So children that would be enrolled in our program have neurodevelopmental impairment. Their functional limitations must include impairment in either the eating and or breathing area, and they're not followed in another multidisciplinary clinic. So as Dr. Miller mentioned, there might be children who have cancer or chronic kidney disease. They're already followed in a multidisciplinary clinic setting. So the next recommendation is to build capacity within the healthcare system to deliver coordinated care that is holistic, comprehensive, and family-centered to all children with medical complexity closer to home. And this involves all of us working together. So we need to develop an infrastructure to provide care and services for these children and their family, and this requires collaboration between the healthcare system, the government, acute care settings, community care settings, and families. We want to work towards developing a governance model with well-established objectives and evaluation process, have a sustainability plan that identifies complex care as a priority, have an education model to meet the ongoing educational needs of all of the care providers who are providing care for these children and families, and have standards of clinical delivery. Next recommendation is to identify a key worker or key workers and care team for each child with medical complexity to facilitate service planning and care delivery in collaboration with the family and caregiver. And the key worker can look very differently for different kids. So this may be their primary care provider. It may be community supports like their CDS, ICS, SMD worker. Some kids may need the complex care program. Maybe a nurse practitioner, a nurse clinician. It really depends on the individual situation. But there are some shared goals for that key worker. So the key worker is to be that single point of contact for the family. They work collaboratively creating links between acute care, home care, education, community, basically everyone involved in that child's life. They represent the global interests and the requirements of the child and family, and work towards coordination and communication between all providers in all settings. They participate with the family to identify and connect with their primary care provider, to identify and work towards goals, and identify clinical and non-clinical and community activities. And they would also look at identifying care needs, developing a care plan, educating and coaching the family to strengthen their ability to advocate for their child's health and needs. And they would also facilitate and aid in transitions. So this isn't only, hospital to home, but this is within the care system. This is within levels of education. This is transition to adult care. So there are a lot of points of transition that are really important for them to be working with the family. Next is to develop and maintain a shared single care plan with common language and clear ownership for children with medical complexity that is accessible and updated in a timely manner. So this is to be developed by the key worker, and there's input from the family and healthcare team. It's updated after clinic visits and major healthcare status changes. It includes all of their needs, clinical and non-clinical, urgent care recommendations, resuscitation guidelines. Ideally, it's a part of the medical record, and the family and the key worker determine who needs to have access. So this is a bit of a busy slide. This is what should be ideally in a care plan. I'm not sure how many people in the room have seen the ones that we've developed. We do try to include all of this information, so they can get a bit lengthy, but this is in line with what's recommended with the CAFC report. Next is to empower families by proactively supporting them to develop skills, competency, and confidence to comprehensively care for their child, navigate the healthcare system, and advocate on behalf of their child. So caregivers need to be given the opportunity to learn about their child's condition and acquire the necessary skills to provide for them. The caregivers need to be recognized as key members of the team, and their expertise should be acknowledged. Look at practicing shared decision-making, guide and coach them on how to navigate the system and access the resources that they need, support them in their home care management. Care planning should also occur with families and include suggestions for management of illness or complications that may occur. There needs to be ongoing training and support for all of the healthcare providers to be able to support families in this way. And families should also be actively involved at the system level as we're developing our program and recommendations. And then organizations providing services to children with medical complexity must have a strategy to transition between levels of healthcare and different care environments. And points of transition are really important. There are times where if it's not done appropriately, we can see lots of readmission, we can see things being missed. So transitions are really key. So there should be policies and processes for communication with all the other levels of care. Discharge planning should include the community. So it should be including people in this room when kids are leaving acute care settings, they're coming back into the care of their community providers, and we need to know the plan. Discharge planning should happen well in advance of discharge. So it's not, okay, we're discharging next week, let's talk about it. This starts at the time of admission, and it's an ongoing process. And there should be meetings before discharge that include all parties, so we can answer questions, discuss concerns, and get a better sense of where the family's at in terms of being ready for discharge readiness. The care plan should be reviewed and updated. Ideally, there's also a one-page summary that's always updated, that's with the child at all times, so that people always have access to the most critical up-to-date information. Critical or essential clinical information resources need to be given to the caregivers at time of discharge. We need to empower families through education about self-management, so they should be confident and have been able to go through and demonstrate the skills that they need to be able to do at home. Medications need to be reconciled, and care coordination must be in place. So this is supplies, equipment, transportation, all of this needs to be in place before discharge. So coming back a little bit to what we're doing here in Manitoba, as Dr. Miller mentioned, we're primarily an outpatient service. So within our clinics, children will have a comprehensive review and assessment. They will have their full feeding assessment done at the same time. We review goals with family. We go through all of their appointments and subspecialist recommendations, and anything that's missing or lost, we will track down, update their care plans. We do a lot of forms, so parking, disability tax credits, that kind of thing. And then there's a lot of time spent outside of the clinic in terms of phone calls for, questions about same-day sick management, appointment reminders, that sort of thing. A lot of time spent coordinating care, so connecting with the different specialists, especially for families that live rural and remote. We really try to make sure that if they're coming into the city, we've been able to coordinate as many of those visits in one time down. Like if you're flying for 5 hours for one appointment and then you're flying back the next week, it just makes no sense. It's really disruptive for the family. And it's also a lot of cost for the system that doesn't make sense. So a lot of work is done on that. And two, if there's different recommendations from different specialists, we'll try to get everyone on the same page. We'll organize team meetings if needed to discuss some of the bigger issues that require people to come together and get on the same page. In terms of inpatient services, so this isn't fully developed yet, but we will identify children who would benefit from our program, or we will get consults from the inpatient services. If our kids are admitted, we will try to track down that they are actually there and liaise with the team if there are things that are outstanding or they need to know. Collect all of the information that happens from the admission. If there's family or team meetings, we'll also attend those. So next steps, there's a lot more work for us to do to further develop our inpatient services in terms of really being involved earlier on to help with that ongoing discharge planning and facilitating team meetings, family meetings, and getting those care plans done earlier. So that is a goal for us down the road as hopefully our capacity increases over time. Brain injuries, so this is a program that hopefully will be coming down the pipe to be a little bit more organized. A lot of people in this room are already providing a lot of excellent care for children with acute brain injury, but we are trying to develop a multidisciplinary organized outpatient program. Cerebral palsy program, so again, I know people in the room are involved in this discussion. Really, we're doing lots of pieces of this in our center, but looking at just increasing coordination and flow between what everyone's doing and identifying areas for us to further grow and develop to make sure we are addressing all of the care outcomes that we should. And then I should have changed this too, since central intake is really confusing. This is not central, this is not replacing the therapy central intake form, but we are looking at a form for all of the rehab clinics. So instead of referrals to different clinics, we're looking at one central sheet for community providers to send in so that we can triage where the kids need to go. And really the goal is that when we are getting these referrals, we can make sure that kids are accessing all of the different areas in the center that they need to, so that there isn't any delays in timing for treatments that they need. And also figure out where they need to go to first, because it can be a little bit confusing, you know, which clinic might be the best place to start. So we're really trying to improve efficiency for ourselves and for the families so that kids are accessing care at the right time. So just to kind of come back in and wrap up the case that we presented at the very beginning. So what does this look like in our clinic? What would we have done? So before clinic, we would have done the chart review. So just as an example, as things that might come up in this case, we found 2 other chronic conditions that had been lost to follow-up, so we were able to reconnect the family with those specialists. Within clinic, we did our comprehensive history and physical, assessed goals, did our nutrition and feeding assessment, and did some family education. And then after clinic, so in collaboration with subspecialists, we developed some acute care recommendations, so breathing action plan with respirology, seizure management with neurology that we're able to incorporate into the comprehensive care plan. Made sure the care plan was sent to the local ER, so not just our child health resources, but the rural care team as well. Coordinated subspecialty follow-up so that the next time the family had to come and drive into the city, they're able to see multiple specialists at once. And then looked at coordinating care within the rehab center. So I identified this child also needs to be seen in our spasticity clinic and our ATC clinics. We're able to look at coordinating those appointments at the next visits and also having more community supports present in those visits as well. So therapists and community support workers so that they can get all of that information and be there with the family as well. And then ongoing care, so tax credits and parking forms were filled out. Daily support was available for the family, so phone calls for intercurrent illnesses and appointment management. And throughout the process, really working on family empowerment. So as they're learning more about their child and the system, for them to gradually be taking on more and more of this coordination on their own. So I hope that we've met all of our objectives and that this has been helpful to learn a little bit more about our program and where we want to go. And I will open it up for some questions. Yes.
In one of the much earlier slides that Dr. Miller was talking about, I think there was a number 2,300 kids in Manitoba. I think only 260 some were aided by technology.
So, oh, I'm sorry. So the question was looking at that estimated prevalence within Manitoba, and just a question about that you'll get from my explanation. There's webinar people. So that 2265 or whatever was, if we were to extrapolate that 0.67%, which that number was based on, did they have one of those diagnoses? When you look at kids that have those diagnoses and have technology, so it's sort of a double, so not just kids with technology, but diagnosis and technology, that's when we looked at, of those 2,200, we're looking at more like 270-ish in Manitoba. And that was because our population times the 0.08%, which was found in Ontario. I will say though, anecdotally total, and no evidence behind this whatsoever yet, I would assume our numbers are going to be higher, just with our sort of founder effect populations, so populations with a higher burden of genetic diseases, the remoteness, the rurality. We start to see a little bit more need and a little bit higher prevalence of certain diseases. So I would predict that's going to be a little higher for us.
And I think what you were getting to, obviously there are way more children who have technology dependence that you guys see in your program. So this is, Dr. Miller said, that subset that would be considered children with medical complexity that have high fragility and would need this program.
Any webinar questions?
No. I even asked them any questions and
I never know, is that because we're so clear? Or it's just, yeah, too early? I don't know. Okay. Thank you.